You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
So, hello, everyone. I'm E. I'm one of the medical students working on the Just Medicine podcast. And today we have two amazing, knowledgeable speakers. And so we have Dr. Fraser Black, who is a palliative care physician working out of Victoria. He was one of the inaugural founding members of the PORT team, and he has had more than 25 years of palliative care experience, leading various initiatives in Canada as well as globally as well in many countries, including Nepal, India, Tanzania, and Brazil. We also have Ashley Mollison, a PhD student with University of Victoria's Interdisciplinary Social Dimensions of Health program. And she is an experienced researcher who has been exploring inequities that people face when accessing healthcare. Her findings are further supported by what she has seen, experienced, and learned firsthand through more than 15 years of work, activism, and caregiving in context of poverty and homelessness. So without further ado, I will begin just by asking exactly what palliative care medicine is and what its goals are, because I think we have a lot of junior learners who might not have had any exposures to it whatsoever. So just wanted to really define that for our listeners.
Right. And I'm happy to start with that one. In fact, it's something that historically hasn't been taught a lot in medical school or nursing school or residency. But I'm really glad that it is being taught more, certainly than when I was a medical student. And when I think about palliative care, it's kind of interesting. And I kind of laugh about this because I think when people ask like surgeons or surgical teams, like, what do you do? What is surgery? Like, I don't know that there'd be a lot of debate necessarily about what surgery is or surgery isn't. Although in the advent of, AI and stuff, maybe like the definition might change. But hospice palliative care has been something that keeps being defined and redefined and discussed. And I don't know about you, Ashley, but I've found myself in a number of conversations sort of talking about how hospice palliative care has changed and people still saying like, what is it? And so, I think again, without sort of necessarily just relying on definitions, I thought it was interesting going into this podcast to say, well, I was curious to see what the Canadian Hospice Palliative Care Association had as a definition for hospice palliative care these days, because again, it has shifted. And so the Canadian Hospice Palliative Care Association says that it's a specialized form of healthcare that aims to relieve suffering and improve the quality of life for those living with a life-limiting illness, as well as their families. And I sort of thought about that, and I thought, yeah, that kind of gets at it, because palliative care helps to support people, with the physical, the psychosocial, the social, the spiritual, and the practical pieces as people face, maybe not the very, very end of their life, but it includes the very, very end of their life, but also just life-limiting illness. And so, and as you heard in that definition from the CHPCA, we really, want to have, support not only of the patient, but the people around the patient. And we'll use the word patient, but we could use client, or, we could say person, because patients are people. But, I'll slip into that patient word, but really supporting not only the patient, but the people around that person. And palliative care extends beyond when that person dies. And so grief and bereavement is an important part of the work that palliative care does. Again, I won't use the whole podcast to sort of like keep talking about what palliative care is and what it does. But there's an interesting thing that's happened in palliative care. And again, Ashley might speak to this later on as well. But there's something now that we talk about which sort of shifts things and brings palliative care upstream. So we talk about a palliative approach to care. In the past, when some people thought about hospice and palliative care, they thought that it was like when all other sort of disease modifying treatments had finished, or when somebody said they didn't want antibiotics anymore. But a palliative approach to care really allows us to work with people and again, with the person who has a life-limiting illness and the people around them, because they're already probably facing symptom issues, grief. They're all, spiritual kind of questions, existential questions. And we know that palliative care can improve quality of life. So a palliative approach to care actually allows us to kind of be involved upstream when people maybe still have interest in getting chemotherapy, when people still are, interested in getting antibiotics or dialysis. And certainly in a setting when end of life isn't so certain. I think sometimes we have said, oh, well, unless we're certain that someone's dying, we shouldn't start palliative care or we shouldn't start the conversations. But so many things that Canadians are dying from now are not necessarily straightforward. Congestive heart failure, COPD, dementia. It's not always exactly clear when death is going to happen. So if we wait until the very last moments when it's very obvious that someone's dying, we miss the opportunity to really help improve people's quality of life and help people around them. So again, I could say a lot more, but maybe I'll just say, I think palliative care is about living. Even though with people who are at risk of dying, it really is about living and improving the quality of life for that person and the people around them. So actually, I've probably said way too much. Maybe now it's even confusing. People are like leaving this conversation going like, what is palliative care?
No, I think that was a great response.
Yeah, likewise. Yeah, I feel like, it's really lovely that you frame it that way, because I personally felt like that was my experience with my rotation as well. And I think that's what's so lovely about palliative care, is that we really get to engage in patient-centered care. And, not all of it is necessarily algorithmic or following guidelines, but it's really, being there for that patient and their family during a really pivotal part of their life. So I really like that. It's not just about, death, but it's about living as well.
Mm-hmm.
And so with that being said, I think, both of you work on a really special, sort of even more nuanced subspecialty, I guess, of like palliative care. So what is PORT exactly?
Yeah, sure. And maybe I'd sort of start off to say, like, although there is so much known and we know that palliative care improves quality of life, we actually know that palliative care can extend living too for people who have early intervention with things like lung cancer and things like that. But so many Canadians don't actually have access to palliative care. So many people don't have access to palliative care. And people who are facing structural, vulnerability, who are vulnerable, who are stigmatized, who experience racism, who have, a history of using substances, it's even more difficult for people to access palliative care. A lot of our palliative care programs that we really celebrate, and support people who have a home, who have a phone, who have somebody that can help them and journey with them in this process as their health deteriorates and as they go on to dying. So PORT, Palliative Outreach Team, really recognizes that we need to do things differently. We need to meet people where they are. There may be other things that we need to help to support. And as Ashley and I begin to talk more, we'll talk about equity. But PORT really tries to help bring and bridge palliative care to people for whom there are existing barriers. Most of the barriers are probably in our system rather than actually with the individual, but the barriers in our system. So the people that are dying, people that are suffering, are not accessing palliative care, are not accessing good symptom control, are not accessing the support for them and the people around them. So PORT is a team and people around that team that go to where people are. And again, I might talk more about it, but it's interesting too. We receive referrals from many different types of people, and so we're a low barrier service, we say. And so, yes, we get referrals from healthcare professionals, but we also get referrals from people working in different housing organizations. We get referrals from other patients. We get people that are working with people in some of the community agencies. We even get referrals from the police, and we've had a referral from a bylaw officer who I think just really was struggling with kicking someone out of their tent every morning that looked like they were dying. And so Port helps to bridge people, helps to support people for whom the regular, I'm air quoting here, you can't see that because this is a podcast, regular palliative care services that can be great, don't often support these individuals. Ashley, anything else you want to add about that?
I would just add, like, just practically, Port is a physician, a nurse coordinator, a health outreach worker, and also a social worker right now. And there are administrators and things like that, and academic, partners around, which is kind of where I came into the picture around doing research, leading up to the Port service and after and alongside. But I would just say that it's a diverse kind of like interdisciplinary team that really can use their like leverage in different places depending on their role, like having a physician that's able to talk to physicians and having social workers that are able to connect with people in the community that are working in the services where people are living and dying is a really big strength of Port.
Yeah, such a good point, Ashley. And actually it's a big strength of palliative care too. And I think we've always in palliative care and now, in other areas too, it's not just palliative care that talks about team, but certainly we've recognized from early on that interdisciplinary team, that broad interdisciplinary and interprofessional team is so important and to providing this kind of care.
Yeah.
And so for both of you, how did you become interested in this work with Port?
Should I start?
Sure.
As someone who's not on the Port team.
You kind of are.
What are you doing in this conversation? So I began working up at University of Victoria in 2015, and I had been that's when I started working with Dr. Kelly Stadjahar, who is a nurse researcher up at UVic. And prior to that, I had been working in community settings. So I was mostly working in harm reduction. I had most recently been working at AIDS Vancouver Island, or AVI, and then Solid, which is a peer-run drug user organization. I worked there for a few years, and a lot of the work was really around trying to advocate for better access to care for people who use drugs in particular, but also people that were facing other barriers to care, homeless, poverty, racialization, lots of barriers going on in the health systems. And it was really, a lot of the work at AVI and Solid was really like emergency response, and particularly for people like this was kind of 2012 was when we really started to see a lot of increase in like overdose deaths and lots of diseases that were not being seen, treated, going and escalating, getting worse, lots of wounds on the street, which continues to happen, and the overdose toxic drug emergency just continues to get worse as well. So I think that was a lot of the work. And so when I started working with Kelly, like I didn't know anything about palliative care, but I learned from Kelly and the team and Fraser and other people that were doing that work. And by seeing kind of the impact of palliative care, I was like really shocked and surprised about this area of healthcare, because I started to kind of see this approach to care that was really around the person. And like, recognizing, and what Fraser was saying earlier about, you know, quality of life, like what does quality of life mean to you? Like, and I think that there is this kind of thing that happens when treatment or fixing a disease doesn't really become the priority. Of course, that can be part of palliative care and it can be integrated. Like people can be getting treatment while getting a palliative approach to care. But, there's just something that happens where when like all of a sudden it's not really the system's priorities and the physicians and aren't necessarily the experts in care anymore when, treatment isn't the goal. And then all of a sudden it's like, well, what does success look like for you in this relationship? Or like, what do you want your life to look like? And all of a sudden I started to kind of see, and like by doing research with people and seeing what the impact was on the ground, I really started to see like people being asked these questions that I'd never heard asked in the health system, and also people like expressing themselves that it was the best treatment that they had ever received. And it wasn't until they were dying that they got access to this kind of care. So like people who use drugs that had been, for example, self-managing their pain by illicit means, all of a sudden, being able to say, I have this pain, I have this advanced cancer, and then getting legitimate pain meds. And that was helping so they didn't have to go to the street. So it was like, oh my God, like I can actually get my pain needs met by the system. I don't have to do that myself. People that were getting access to the kind of like housing and support that they needed for a really long time, but then, because they were declining physically and stuff and couldn't get around much anymore, then they got housing. So it was like, I just was like, wow, like, it just made me think a lot about the value of an approach to care that really is person-centered. We talk about person-centered care a lot, but really like looks at the person and asks them these questions about what quality of life means to them, and then does everything that it can to really try to meet that quality of life. And I think we see that so much in the Port Service because of their ability to not only meet medical needs, but also those really important social needs, like getting people access to housing and, income support and food support and all that kind of stuff that Port does. Expanded scope of, of healthcare, which should be part of healthcare, but isn't. So, yeah, so I just really saw, I think, what drew me into palliative care and what made me become a palliative care lifer is just really this like approach that was just like, you're putting your money where your mouth is. You're really not only saying the words, but you're following through on the actions of getting people better access to care. So that was what drew me in and made me stay.
Me too, a lifer. I love that. Wow, I knew all of that. Ashley, it's so great to hear again because we haven't talked about our stories together for a while.
The origin story.
The origin stories. Yeah, for me, I think that it's been very interesting sort of looking back on a career, and I'm not done yet. But looking back on my career and things were different then, as I said, in medical school and in residency, they didn't talk a lot about palliative care. I had a very fortunate opportunity and like an aha moment in my family practice residency to work with a family physician who was doing palliative care. And it was almost just as I was coming out of residency that I realized there was a thing called palliative care. So when I became a practicing physician, I'd already done a little bit of extra training in palliative care, but I knew I wanted more. But I also had an interest in inner city medicine and I worked in the downtown east side actually for a number of years while I was doing more palliative care. And then for a period of time, I did just palliative care. And then now some time ago, got back into doing inner city medicine. And Port, and we may or may not talk about this, but it's actually Port's been around for a long time before there was like a Port service. And so the work that Ashley and Dr. Kelly Stadjahar were doing and the research that was being found, and then this idea about a clinical team. When it came to 2019, when there was going to be the clinical team, I was just like, oh my goodness, this makes sense. I worked in the downtown east side. I'm an inner city family physician. I've been doing palliative care for decades. this makes so much sense for me. And I will say, when we started doing this work as a team, I had so much to learn. I still have so much to learn. And so even though I'd been practicing palliative care for decades, even though I've been a family physician for decades, I learned so much each and every day doing this work with Port. So it's definitely something that for me is really exciting right now to kind of bring these two sort of big parts of my medical career together. Go Port.
Yeah, I think I almost like it just was so revolutionary too, as well, when I was doing the rotation to just hear this like integration of inner city medicine with palliative medicine. I was just like, whoa, like, yeah, it makes so much sense, right? But you just don't hear about it as a student. And I also kind of like, unfortunately, I didn't have the experience of working on Port directly, but I also was like, wow, just even hearing about it, is quite awe-inspiring. And the fact that it exists for our vulnerable folks out there is really, really important. And so I guess like this question is more focused on the research, but Ashley, for you, like what insights have you learned about the research that you've done on Port?
So this is a hard question to answer because I realized that 2015, when I started doing research with Kelly and the teams, that was like 9 years ago. And it's almost been a decade of research. So I'm not going to be able to summarize everything I've learned. But I guess just to kind of give a quick overview of what we've done so far, like we've really, like we started off with a study that was really about trying to understand people's experiences on the street. We followed people around who were actually dying. We integrated ourselves in their life and really tried to understand what their barriers of care were, and what was helping them to access care. And then for the last like 5 years-ish after that study, we really have been focused, our projects have been really focused on working really closely with inner city workers who work in the shelters, work in the housing, in inner city health and harm reduction, peer workers, to just really like understand how they are seeing palliative care, like how that care is happening. It might not be called palliative care, but like, care work is happening in inner city settings. People have their strong communities of support, their street families, their workers, their other, folks in their life, sometimes, biologically connected, legally connected family that's also there providing care. And then we've done a lot of research just with these teams, like across Canada, Port in Victoria, Camp in Calgary, Peacoat in Edmonton, and then Peach in Toronto. And then there's lots of other models happening across the country as well now. So yeah, it's really been cool to see like from the beginning of the research and just really trying to even make visible that there are people that are dying on the street, because of course we know that, but at the very beginning of the research, it was like not a lot of thought went into what happens to people who don't have a home and are dying and or living with serious illness or declining in whatever way. They often just got shipped off to hospital and then died in hospital alone, or, died alone in single room occupancy of hotels or whatever, right? And so there wasn't that kind of palliative care awareness. And so I think it's been really cool just seeing in the last almost decade the shifts that have happened around these issues being brought to light. And then I'm really kind of just excited about these, like the understanding and what we've learned over the years, that this is really the biggest kind of like thing I would say is that it isn't really about, the goal isn't about kind of bringing palliative care services to homeless people, but really about working with the ways that homeless people are receiving care, how the inner city works, how the agencies work, how people in the tent cities and their own communities work to care, and then understanding how palliative care can be a part of that. So like, it's really kind of that like meshing together of the knowledges of palliative care and inner city work, as you were saying earlier about, inner city medicine and palliative medicine. It's like bringing the two worlds together, as opposed to thinking that palliative care is the expert and putting that on people, because there's lots of really important reasons why people don't want to engage with palliative care. Lots of what we found in our studies is, people are just surviving. People are like focused on acute issues. They are like, finding food, finding shelter. It's like, it's not necessarily the time to be like, can we have a goals of care conversation when people are like, have these like really important immediate needs that they're attending to. And, healthcare people might not be the person to even have those conversations. They might be, for sure. Like, they might be helpful in that. But like advanced care planning conversations or whatever, it's like, how do you kind of mobilize the existing support that people have to, and see and make like visible the support that people have, and ensure that those workers and the street family and the chosen supporters of people like are actually respected and heard as the chosen supporters when they enter the health system. Because that's like a big problem, right? It's like people aren't really, if you're not family, or, you're not seen as somebody that can legitimately speak for a person or whatever. So I think that there's lots of learnings, but I think that the biggest one is just around like the need to like strengthen, hold up, and build capacity. Capacity is there, but recognize capacity, I guess, is the better word, for what's already happening in community.
Yeah, thanks for that really lovely, insightful answer. Because I do think that, yeah, oftentimes there's an idea of like what we want to do in medicine, I suppose, and then I think especially for these patients as well who might have not had the best experiences historically, like we have to recognize that we truly need to like meet them where they're at and engage all the supports that they already have in those communities as well.
Mm-hmm.
So I think you touched upon this a little bit. I wanted to hear from both of you as well. What are some unique challenges that our patients face in this context that perhaps like we might overlook?
Yeah, and as you say, I already mentioned some of them, and again, I always am amazed still at housing, and when I say that, I mean the lack of housing, and so that I think again is unfortunately less and less unique to Canadians. Homelessness is on the rise, but still, what a challenge homelessness creates for living, and what a challenge homelessness creates for dying. And so, absolutely homelessness. And then, as I mentioned, again, just those assumptions that like people have a phone, people have a fridge, people, have transportation, and people have, and again, Ashley and I have talked about different things. We often talk about like have a somebody. And it's amazing, that some people don't have a somebody, or that their somebody is, somebody that you wouldn't expect would be their significant somebody, like a housing worker. And so trying to find out, does that person have a somebody? What, how might that somebody be able to support that person if they're wanting to enable, and how do we help support that somebody? And so again, one of the unique challenges is often just very practical things like, I don't have any food. So, it's not uncommon that we're bringing food, that we're providing a phone, that we're getting more minutes for a phone, that we're, trying to help people who are having physical decline if they are somewhere that they're paying rent, like in a single rent occupancy. Like, how can we make sure that they don't get evicted? I think the other challenge is sort of looking at the other side or another area that, is just all the challenges. And you sort of pointed it already. And that is that like the healthcare system and people feeling, that it's not safe to go back into a healthcare setting, to go back into a hospital, and just that experience of not being respected, of being discriminated, about not getting your needs met, including the need for medications if someone's in withdrawal. And so the challenges of that yes, we have this healthcare system, but the experience that people have had it, and it isn't something that they're really wanting to go back to. So people having illnesses that might otherwise, be so-called, air quotes again on this podcast, treatable. But it's sort of intolerable to go back to the hospital for that person. And so how do we work with this now life-threatening, life-limiting situation? Because going back to a hospital is not an option. I've had more than one, but I've had a patient who extubated themselves in ICU, walked out of ICU, and the port team was met in a park like 4 hours later. So these are people that have a strong need to protect themselves, and sometimes the way that they protect themselves is not being in harm's way in a hospital setting. That's the unique challenge.
Yeah, I mean, I would echo everything that you said, Fraser. I think that, one thing that came to mind when you were speaking is we have a good colleague named Holly Prince, who's a Anishinaabe scholar and an educator. And she always reminds us that the Western health system wasn't set up to care for Indigenous people. Like, it was part of the colonial project, right? And I think that we have so many assumptions about our health systems. Oh, they're helpful, they're caring, blah, blah. But if you are not someone that's well housed and well resourced and middle class, white, it's a different experience. And I think that's so important to recognize that when people are coming to healthcare, it's often because they've exhausted. In this community, it's often because they've exhausted all other resources. Like they've really tried to look after things on their own, and they've gone to friends and they've tried to deal with their health concern. Oftentimes, like, this is a big, like, kind of umbrella statement, but it is that, like, when, that choice is made to go to the ER or whatever, it's like, or to look at that lump that you felt for a while, and think that, we really need to get this looked at. It's often like at that later stage, right? And it's not all because of the avoidance of care. Sometimes it is that people have gone to try and get care and they've been dismissed, as Fraser said, haven't been believed. People have thought that they've, been trying to seek drugs or whatever, right? So I would just totally echo that. I think we have a system that's very much built around these assumptions that people like have these kind of, strong support networks to care for them in community. And as we know, resources in community are going down and down and down. Homelessness and poverty is going up and up and up. So I think what we're really going to be seeing is more and more need, and health systems that are less and less able to meet the social needs of people. But that's the place where kind of the rubber hits the road, right? With the health issues, that's where these social needs and the social problems really start to show in our system. And so I think so just to say that I think this idea that kind of like medical, like that healthcare is just medical care is a really big problem. And it's a huge barrier for so many people, and not kind of thinking outside the walls of what did the person have to do to kind of get in here today, how brave and courageous they were to kind of get through the door. And then like, did they have to forego a meal to be able to come and sit here? Or are they going back to go live on the street or in a shelter where they can't keep that wound clean or whatever? So I think it is the social needs, but also it's kind of healthcare's recognition that there is all of these compounding factors that are gonna like make that person's situation so much better or worse, right? So yeah, that's what I would say, just to echo what you said, Fraser.
Well, I just want to say that what you said was so very nicely said.
Uh, I think that just hearing from both of you, I mean, like, it's really interesting because even as such a junior learner, speaking to, all of my friends who've gone through just, the couple months of clerkship and electives we have, like, I think we've all met a patient who has had, those types of unfortunate experiences. And I think it's really easy for us, from a place of privilege to take the medical system for granted because, we haven't had necessarily those experiences. And so I think a lot of these patients get labeled and treated in such and such a way. But yeah, it's really sad that really for a lot of them, the hospital is the last place that they would be because they're really at their wits' end. And they've had, like a cumulative number of experiences that were just horrible and appalling. And so I think, yeah, it's really enlightening to like put this forward. And now that there is more recognition in this system, and there's also folks like both of you who want to change it, and start, have programs like put in place that I think hopefully the tides will change and our patients will get the help that they actually need. So I also wanted.
I want to interrupt. I had the feeling you're just about to ask another question, and you said something that reminded me of something that I think is important to say. And you talked about language, and you talked about sort of those junior clerks and language. And I think, one of the things that we've learned, and we know not just from this work, but from trauma-informed care, and there are other ways of describing trauma-informed care, but just how much language matters and how much, sticks and stones will break my bones, but what is it? Words will never hurt me. Well, words hurt and words get perpetuated. And I think it's a real opportunity for junior learners, as you say, to kind of watch and see the language that non-junior healthcare people are using, and as possible, maybe challenge some of that. I mean, certainly using, language with patients, with people, but also how we talk about patients and people. Language matters. And so really being aware of the words that are being used to talk about people and talk to people. So thank you for saying something that made me want to jump up and down and say, language matters. And as junior learners, you are in such a great place to kind of hear things for the first time or be hearing things that doesn't sit right. And again, not to sort of generationalize young learners, junior learners, but I think that you're in a place to really look at, how things have been done and how we talk about how things are being done. So please, please challenge language when you think language isn't serving or language is perpetuating stigma, discrimination, racism.
Mm-hmm. Yeah, I think, thanks for sharing that because it is so absolutely important. And I think just by saying, things that make make people feel like they're being heard and listened to, it really truly makes all the difference. And I think, sometimes as junior learners as well, it's really interesting to hear about these experiences, just like to be that person, to spend that time to listen. It can actually be quite, I think, life-changing for these patients. So I think a lot of times, like learners, we kind of underestimate the impact of our actions and of our words. So just by changing our language, it can really have a series of, unintentional benefits for people in the system. So
Yeah, I completely agree with that. And I just also was thinking when you were saying, and Fraser was responding too, is like, I think like when we look at what's happening in health systems and like the, the bottom line and trying and looking at the efficiencies and stuff, like we know the time with patients is becoming so like much less and less and less. And so when I talk about people's experience in healthcare, I also don't want to put across a message that it's like all about the practitioner being at fault or their experiences. Cause like I know also too that practitioners are so caught between a rock and a hard place where they're trying to create good experiences for people, but the time is so restricted. But I also really like to kind of make that point. And what you said is that like really understanding that there's so much opportunity in any interaction to improve a person's experience in the health system. Like, like as you said, even that like one conversation where people really feel heard. I mean, hopefully they don't come back and get like the door slammed on their face the next time they come, but it is like that is also healing. Like what is healing in the system is actually being treated like a human, like being, heard, listened to, believed. And I think with palliative care, getting back to the topic at hand, like the time that palliative care practitioners have with people is so much like a part of that healing experience to actually sit and just listen to people's fears and their like wants and wishes and needs. Like, even if they don't jump and do something about it, it's even just having that space for people to express that, which is just such a profoundly healing space, I think.
Yeah, lovely.
all right. So yeah, thank you to you both for those insights. I think just in terms of maybe a bit of the specific symptoms that our patients in this context might struggle with in particular, I think like both of you alluded to this a little bit, but obviously I think if someone is dying, not having access to shelter and food, like the basics, that's going to be really problematic. But yeah, like what are some of the symptoms that really our patients in particular find challenging?
Yeah. Certainly pain. And again, we've sort of touched on that and, lots of medical conditions, not just cancer, come with pain. And for people who, as Ashley was talking about before, are sometimes trying to seek care or seek investigation or seek pain control, but are, again, language labeled as drug seeking, they're not getting the pain management that they need, for that symptom that we don't have a measurement to measure, saying, oh, yes, you do have pain. The person has pain. So pain is such a huge issue. And for many people, they may also have had chronic pain as they come into experiencing more or different types of pain related to their cancer or non-cancer. And, we haven't yet sort of talked too much about sort of harm reduction and the opioid crisis and such, but some people are already taking some of the medications that we would normally use in palliative care, and we can maybe talk about that. But so pain for sure. And again, not just in cancer, but in other illnesses, shortness of breath. Absolutely. Again, many people that we care for have advanced, lung disease or COPD, nausea and vomiting. Again, these are all sort of not uncommon palliative symptoms, but so they're arising in a setting where, that perhaps it's maybe more challenging to deal with nausea and vomiting when you actually share a bathroom. You don't have your own bathroom, or you live outside and you're vomiting and have nausea. Edema, a big issue for a number of the illnesses that people face. Wounds, Ashley talked about. Again, a lot of our patients are sleeping maybe in places and their body isn't able to heal wounds in the way that we would wish for them. So wounds. So, again, what have I missed in the symptoms? Yes, they're also itchy, and then it's all of the regular palliative symptoms, but just the complexity of trying to address those symptoms. And then, not the physical symptoms, but there's so many, non-physical symptoms or non-physical suffering, grief on top of grief, pain on top of pain.
And so I guess like a good segue to that as well is just in terms of the specifics of the different services that Ports provides and then how patients can access them. I know we kind of alluded to it a little bit, but if both of you could expand perhaps.
Yeah, maybe I'll just start off and just say again, we're a low barrier service. And so people can actually even self-refer to Port. We've had Port patients refer other people to Port. And as Port is becoming more well known, and it is, again, thanks in large part to the work that Ashley and Dr. Kelly Sadrahar are doing in researching us and us talking about it. So, we do get referrals from a wide array and our community partners too. So how can people access the services of Port? Well, really, hopefully the people around them, both health professional and non-health professionals, are aware and are looking and are able to ask Port or have a conversation with. Usually, it starts with their nurse. Will sort of maybe a contact point. We also have online referral forms both within the hospital health system and through Ashley and Kelly's work at UVic. So people can access the service. And again, that could look very different. And so again, with the team that we have, it might not really be physician stuff or symptom stuff. It may be practical stuff. And so, again, that's sort of going in and assessing. And sometimes, it's like getting that person that phone, getting that person food, figuring out if that person has somebody who they would want to make decisions for them. And that may be the early work, before, that person even sort of feels like the priority is to talk about symptoms. Ashley will remember, but one of our very first clients was living in a car or dying in a car. And we really wanted to start, him on some opioid because we felt that it would really help his shortness of breath. And he collapsed outside of his car and was brought to hospital. And then he was in the hospital. And again, this was early days. And I'm like, oh, finally he's, in hospital. And now we can start this opioid for his shortness of breath. And I sort of landed at his bedside and kept sort of like, I really think that it's just a low dose of morphine. I really think, and he's just like, my car. Until I went and moved his car somewhere that it wasn't going to get towed and impounded because it was his home. He couldn't talk about his shortness of breath. He couldn't talk about opioids. So he gave me his keys and we moved his car, kept moving his car so it didn't get towed or impounded. And then we could talk about his shortness of breath. Then we could really begin that stuff. So I don't remember what your original question was, but
I mean, that's, I think, really like an eye-opening story just in terms of like the breadth and the creativity of like the folks that work in Port. Because I think, so often our system is very rigid. And I think even just as a junior learner, having been on the wards, there's so many times where like I have said the words like, I'm sorry, but I can't do this for you because, a patient would be asking for something. And unfortunately, like the system just would not be able to accommodate whatever that request was. So I think that story is, it is really like showing, I guess, the, important principles that belie Port in that, like, meeting where patients are at. And then as a result, once we open that door, then like all these other things can follow. So, I guess it like Port can't really just be summarized. And it's really difficult, to just like put it in a box necessarily.
though I'm listening to you and I'm thinking you could be a future port physician if that was your choosing. You definitely have a good understanding of it, and
Yeah. But you're right. The flexibility is one of and the problem solving and the creativity is something that we see as like such a promising practice across all of the teams that exist. Like when you can work outside of the box, it goes so far for trust, for building trust, right? Like for that person to say to Fraser, like, my car, and for Fraser, the physician, to go and move the car, like it's just like, what a power leveler, right? And then it's like, okay, now let's talk about health. Like it is people moving out of their professional identities to that human to human contact. I think that goes so far for building trust and relationship.
And I guess like
see it on the podcast, but I'm putting up a heart emoji in our.
Yeah, that was really well said. I think this is something that I think a lot of friends have wondered as well. Because I think we have had these cases where we have a really, elderly person who is vulnerable and who might not have access to like housing. So in those contexts, and this is definitely like, I know both of your bread and butter, but how do we ensure that quality palliative care is delivered when patients do not have stable access to housing in terms of just the logistics of like finding them, giving them that medical care? Like, how does that work?
Ashley, I don't know if you from what you've Ashley used to research us. She would come and listen to what we were doing and where
I can get started and you can finish. One thing that Kelly always reminds me and the people that she talks to is that, because she actually did her PhD or something, master's or something, I can't remember, but she looked at like this, I think it was for master's actually, and looking at kind of this ideal of dying at home. And, everyone kind of wants to die at home, but then when you really start to look at the logistics surrounding that, it's really hard to support people to die at home. And so we, of course, I think have this kind of, and people, express wanting to stay in the community. So I think the goal for Port, like any other palliative program, would be to do the best that they can to try to meet a person's wishes. It doesn't always end with a person dying in a shelter bed or, in community, but the intervention of Port, we've really seen, has supported people to stay in place longer than what they would have been able to if they didn't have access to palliative care. So I think that some of that work has been really working closely with shelter staff and working with organizations, working really closely with home care to try to get like services in to places. That also looks like, challenging some perceived notions of risk and safety. Some of the places where people are living aren't always the cleanest, aren't always the tidiest. There might be drug use or alcohol, there might be smoking. So it is like finding people who are comfortable even going in and providing care. Challenging some assumptions, because sometimes it's like there isn't really risk, and often there isn't really risk to healthcare professionals, but there's a lot of assumptions about, because a place looks a certain way, then it's going to be risky. So, challenging some of those assumptions. And then I think, Port has been awesome for just being able to like move between systems. So like checking in on people in shelter, in outside, in tent cities, wherever they are, and to try to check in, making sure people have prescriptions, things like that. So I think like I do, and you can add a million other points, Fraser, but I would just say like to start that conversation, I think that the goal is not always dying in place, but the goal is trying, and like it shifts and changes as people start do decline, and maybe they do experience more pain and they're not able to get their pain needs met in community, then they have to go into a hospital or into a palliative care unit. But I think the intervention of Court and the teams across Canada has been very successful in allowing people to stay in place longer, if that's their wish.
Yeah. And that wishes and goals change, as you say.
Yeah.
And the concept of home changes too, right? Like for lots of people, the concept of home isn't always about, the dining room table or the bed that they've slept in for years, but the people around them and the feeling of safety. So, how sometimes home changes and so stated preferred place of death changes too. And I guess another sort of angle to your question is, when people don't have stable housing, asking them, rather than thinking this is, how can we possibly do this? We'll just discharge to the streets and we won't make a plan because they don't have a home. Like working with those people to say like, how could this work? What could be supportive? And people often have routines in their survival.
Yeah.
And they know where some resources are that you might not even know where those resources are. And then so tying in those resources, as part of a discharge plan, being sure that they have access to the medications and not just sending that prescription off to the pharmacy thinking it's going to somehow magically, get to them. So, really, I think, and again, this is patient-centered care and isn't just limited to palliative care, but like really involving that person in a successful plan. If it's discharge, involve them in the discharge planning. How are you going to get these medications? If you don't have a phone, who does? Oh yeah, I always talk to so-and-so. I see them every day. They have a phone. They've said, okay, well, let's get that phone number. And again, as Ashley has said, and I think as we are seeing, our home care services really, valuing the service that they can provide by going places that they didn't used to go.
Mm-hmm.
And tremendous work and benefit and support that can be offered. So again, sort of trying to link people up to home care services, community services, being aware of those. And again, I'm echoing myself, but just maybe sometimes asking the person themselves, how could we make this successful for you? Even if you don't have, air quotes, stable housing.
Right. Yeah. So I think, it goes again to that idea of like really like treating the person like a person and engaging all their supports. And sometimes I guess in a way, like what you were both saying before, almost like letting go of that medical hat a little bit and just like wearing your human hat and thinking about like what resources are already in their community and what does this like person in front of you genuinely want and what their priorities are. So I think I'm cognizant that we're like a bit like short on time, but I don't know if you both mind going over a little bit or what your schedule is like.
Yeah,
because I think we're having such a great conversation here. So yeah, I think we talked about this like a little bit. But I suppose in the like cases where patients do want to get housing, are there kind of like expedited pathways for these individuals, or what did that kind of like look like?
Things are so dire with housing. Fraser mentioned housing as like probably the most significant barrier to care, and I would say that's probably exactly true. I'm calling from Alberta right now, because I live in Alberta. And currently we have no rent control. So at any point in time, a landlord can raise the rent by whatever amount that they choose to raise that rent. It can only happen once a year. But there are people in our community, my mom being one of them, that had a $500 rent increase per month. Seniors that are on fixed incomes, pensions, can't afford it. And so many more people going to the streets, and the supply just of affordable, there's really no influx of affordable housing, no large influx that is going to meet the demand. So I don't know what we're going to do about housing. Actually, I think it's really dire. And I think that more and more people are going to be in a situation where they'll be homeless and needing services like port. So I don't know if you have something to add that's more hopeful.
I wish I did.
Yeah.
I'm sure that there's somebody that could say something hopeful. I guess one thing that gives me hope is that I see how shelters, I see how places have a desire to help support people and have a desire to help support people die. And that gives me some comfort, because if we can, again, all work together and build their capacities within their capacities, and not saying they can do it all, because they can't and shouldn't, do it all. But, I think we will see more people dying in shelters. I think we will see more people, dying in tents. So what can we do, knowing that we can't get housing for them all, or even many or most? How can we build some capacity, and how can we decrease the barriers to them getting to some place, and that may be a hospital or a hospice or a care facility that has low barriers, sort of identifying those places in the community that people might land near the end of their life. But no, unfortunately, there isn't sort of, as of yet, a clear pathway to housing for people who are dying. We, Ashley and I are aware of, some like small numbers of beds here and there that, are being trialed or being proposed or are actually up and running for people, but no, it's not meeting the need. And so we're going to need to continue to think out of the box. Yeah, I'm sorry that I couldn't sort of say, oh yeah, there's just this form, you fill it out and they'll get housing in less than 48 hours.
Yeah, tick the dying box.
Yeah.
Yeah.
I mean, I think, yeah, that's completely fair. And like, there is, I'm glad that, I think ultimately I'm glad that like organizations like Port exist and folks like you exist, because I feel like a lot of the systems that we have are siloed, and like, social services don't necessarily talk to like hospitals, and, there's so many kind of like holes in the system that need to be like, I guess, patched up. And even if we have a housing crisis, like we still have to like talk to each other and like make available all these resources to our patients and the folks that need it. So it's like the fact that you guys have this creative approach, I think in itself will be hopeful for our listeners and for learners. Like I think I'm personally inspired, because there's so many times where people say, there's nothing left. There's nothing we can do. And I think the kind of lesson that I'm taking away from our conversation today is there's creative solutions out there that exist that might not be in a textbook, but if we talk to our patients, a lot of like solutions might arise even just in those conversations. So
yeah, I absolutely do not want anyone to walk away from this podcast thinking that there's nothing to do, even though the housing situation is dire. I think what Fraser was saying about, seeing services like shelters and like supported housing being willing to keep people in place through serious illness to death, even that willingness. I mentioned earlier that, we've been working on projects with frontline workers and really building capacity in Victoria around even kind of seeing a palliative approach in the work that they do. Like And it's been such a cool process. It culminated in this resource guide that we released last year, and it's accessible on our website, palliativeapproaches.uvic.ca. And but yeah, just really, like, as you say, thinking outside of the box and seeing a palliative care as everybody's work, right? Like it is the compassionate communities movement, the compassionate cities movement is all really about death and dying being everyone's responsibility, and for thinking about caring for our neighbors and people in our communities who need that extra support, helping your neighbor drive to an appointment, all these things. Like, I do think, like, homeless people are not different from our neighbors. Like, they are not a different species. They are our community members. And so I do think the solutions are really going to not be in systems. They're really going to be about people helping people. And hopefully we get better health systems and housing systems and all that. But when you look at the mass amounts of people that are in need, all we really have is each other. What we have is our ability to help our, like, common person, our human connection.
Yeah, no, thank you so much for sharing. I mean, like, I certainly feel so much more hopeful.
Yes. We want to keep the tone hopeful.
Yeah.
I brought it down a bit with housing, and it's back up.
And say that web site again.
Oh, yes, the website. So it's www.palliativeapproaches.uvic.ca. So that's where you can access a bunch of information on Port, on the research, on our resources, on our academic articles, all that stuff. So that's,
you might even put a link to this podcast there, and then people could get in a loop. Just keep clicking and clicking. And,
perfect.
Yeah.
I'll put that in the show notes as well. So thank you for sharing that, Ashley.
Yeah, no problem.
I guess this is a good segue, and, like, both of you have touched upon this a bit already, but what has been the most rewarding part of your work with Port?
Wow. So much. And, boiling down, it's going to be the individuals and the communities. So the individuals being the people facing serious illness, and just hearing from them about their journey with serious illness, but also their journey in life, and their survivorship kind of piece of just like, wow. And the insights that people have in living life and now dying. And that's not just, with people who the Port Service falls, because it's with everyone. We're all human. We all wear that human hat. But for me to be talking with people who are dying, who have lived a life that, many of us couldn't imagine, and to hear the thoughts and ideas and beliefs about living and dying is profound. Living a life of struggle and yeah, as Ashley said earlier, and then maybe in dying and then death, dignity at last, or getting the care at the end that they had wished that they had along. So I'm often inspired by the journeys and the stories. I'm inspired by the people around these people. And again, that often isn't sort of the mother, father, brother, sister, daughter, son, or even partner, but the other people that you might not think of as family, or that you might not think of as a somebody, and just the things that they show up with for people. Again, Ashley talked about that sort of, people coming to be people with each other and supporting each other. And so that individual showing up of people, and then, again, broadening that out, the communities. And just, I've, through this work and through Ashley and Kelly's relationships with people and with communities, like, I've just come to know and be with and in amazing communities of people doing amazing work that, isn't healthcare per se. And I've learned so much from that. And I say I've learned, stuff about myself, and so, yeah, I think the rewarding part is the people and the communities and the growth.
Yeah,
And working, yeah, and
no, that's okay. I think the people, I'm not a, practitioner, but I've spent a lot of time with people just learning about their lives and their stories and finding out from their perspective what would make a better system and a better world to live in. So I think that that's definitely the best, most rewarding part of the work. And people are brilliant, like brilliant, and a lot of times too smart to be living in this system. And don't consent to it and don't condone it. And want to live free lives and want to live more free lives. People are no bullshit. And that's particularly at the end of life, I think, like when there's really no facade anymore. And I really, really love that kind of honest kind of place. And then I think I've been really rewarded from being involved in the research, because of the close kind of relationships that we have with, people that are doing the work like Fraser and like others in the community. Just being able to see kind of how research can be done in an applied way that kind of results in action. Like we're always collecting, synthesizing, putting that back into communities and to systems. And it's really about not just, producing knowledge for knowledge's sake, but about using what we learn to try to improve the situation for people who are living and dying, but also for people that are working in these systems and stuff. So I think that's been kind of rewarding. I don't think I could do just straight up research that resulted in publications. That's not, my style. I think I would not feel fulfilled. And so what's kind of kept me going for this long has definitely been that seeing the action and seeing what comes out of it and what we're part of, because it's not like we wait till the end of a project and then something comes out. It's always happening simultaneously, research, practice. It's just always happening. And it's an exciting research program to be part of.
And, we again we've talked about it a bit, but we haven't emphasized the point that, I really truly believe and Ashley will be maybe humble when I ask her, but like Port wouldn't be here if it wasn't for the work of Ashley and Kelly Stadjahar. Port is here because the research that they did in that Too Little Too Late report, probably available at palliativeapproaches.uvic.ca, really highlighted, gave voice, shone a light on what was needed. And it was through that research, through that being seen and no longer invisible, that we could look at getting some catalyst funding. And then the research that's still being done changes our practice as we look at what we're doing and what others are doing. So yeah, research into action. Mm-hmm. And again, like if I pick the top 10, describe yourself, researcher wouldn't probably be, I'm not sure where it would be placed, but I've so valued being a part of the research, feeling really inspired by it and really supported by it. And so, yeah, it's been so great to see research into action.
Yeah, it really sounds like Port is just such a dynamic team, like the research to action piece. I think that's so rare. I think a lot of the time, yeah, there's so many, I think, just parts of different systems that, yeah, don't really talk to each other. And it's just so lovely to see that Port is so well integrated. Every member of the team is contributing to changes that are happening in real time. So I think that's yeah, I would imagine that work is very special and rewarding. I think also wanted to ask this as our last question of the day, and I really appreciate both of you spending this time with me. But I know that we tend to have this lens in medicine where we're focusing on, struggle and equity and all these kind of problems that marginalized populations face. So what are some resiliencies that we might be underlooking from kind of our lens in these communities?
Ashley, do you want to start?
Sure. I think that it's all resiliency. I don't see it any other way. I think, part of what we really, I think, try to, even the way that we've talked to you in this podcast and really kind of focused on the survivorship of people and their ability to, just, access care despite all of the things and despite the kind of past experiences, ongoing poor experiences, all of the barriers, not having housing, not having a transportation and money and having to find food. And there's just so much going on at all times. And so I don't know. I see it as all I just see that people are very, very, very strong. You think about in your own life about medical issues you've had or what you've supported other people through, whether that be showing up and getting your blood work results or going through cancer treatment or whatever it is, and like how hard that is. And then think about when people are living on mats and getting to their cancer treatment every day. It's just mind blowing. And I think if we focused more on in society about the strengths of people and just really acknowledging that resilience, like in a real way, I think it would look like our solutions would look so different. And even how we define the problem would look so different. It is so not these poor people over here doing this thing. Like it is, wow, like that's incredible. And how do we support you to achieve your goals? Because you have goals, you are trying the best that you can, and you're achieving a lot. And we have put so much barriers up for you. Like, it's amazing you are achieving that despite the obstacles of the system. So yeah, I would just say like, it's all resilience for me. Like, yeah, I don't know.
Yeah, I mean, I wish I wasn't going to speak after you spoke again because I think that's amazing. We could have like just stopped there. But yeah, I think the other piece of that is also trust. And I think, it's been my observation that sometimes we watch people and we're looking at what they're doing or why they're doing that or why they're prioritizing this over that. And it's like, we think, what are they doing? Or can think that, or I see people looking at that or judging that or labeling that. And so sort of in a piece of resiliency is like, often the things that people are doing may not appear to us as though that's what they, air quotes, should be doing right now, but it's what they need to do right now. And it may be what they need to do right now so that later that they can do something else. But in the moment, what people might be focusing on or what's important or what they're doing that doesn't seem to be part of sort of our plan for their health may very well be what they should be doing, that they know what they need to do right now.
Yeah.
And how they do things. So really just to, again, in that sort of, I guess, model to sort of think like, not that they're not doing what they should be doing, but sort of trying to support what feels like they're saying that they need to do for themselves right now. And that might be moving their car,
yeah.
or, that might be doing something else, or not showing up to their appointment, or, not doing the things that we've, think that they should be doing. So, just trusting, as Ashley has said, I mean, there's resiliency everywhere. And that includes, in decision making, and to try not to sort of judge that or think that. isn't the case.
Yeah, wow. I think I'm personally, really awestruck by all the insights that you both shared. And like, thank you again for the opportunity to speak with both of you. Because yeah, I really think that our listeners will benefit a lot, from listening to our conversation, today. And I do feel hopeful that overall, the paradigms are changing. And I think there's going to be like an element of palliative medicine in all of the medicine that we practice, in the future. And I think, yeah, by having like conversations like this, we are, destigmatizing, vulnerable populations, and we're going to be, changing kind of like these established ways that perhaps just, aren't the right ways, to like make way for something different and more patient centered in medicine. So, yeah, thank you to you both again, for taking the time. And I know that it is Friday afternoon. Conversation went over time by half an hour, but yeah, thank you to you both again.
Thanks for inviting us. It was great to be part of it.
Mhm.
Thank you.
Thanks for tuning in to Just Medicine.